I see that there's an increasing number of videos and other media talking about coronary calcium scans, which is great because I go back about 30 years when I first started doing coronary calcium scoring. It was so long ago that we didn't have CT devices to do this. We had something called electron beam devices that focused the X-ray beam with magnets. It was a fantastic technology, but it was a competitive problem for one of the big imaging companies, and they bought the company and the intellectual property surrounding that technology and put it in a closet and closed it and locked it up. So that wonderful technology has now been replaced by what's called multi-detector CT devices, and they're good. I don't think they're as good as the original electron beam devices, but they're still very reliable, and they have made CT heart scans and coronary calcium score accessible, often priced at around $100. The history of coronary calcium scoring started with Dr. John Rumberger, a friend of mine who was at the Mayo Clinic at the time, who did an autopsy study in people who died of all different kinds of reasons, and he examined their coronary arteries, and he showed that regardless of age, sex, or cause of death, that calcium occupies 20% of total atherosclerotic plaque volume in the coronary arteries, meaning that visualization, quantification of the calcium in the coronary arteries could be used as a gauge or an index of how much total atherosclerotic plaque you have in the heart's arteries. Because before then, there was really no easy way that was non-invasive to gauge how much coronary atherosclerosis you had. You could do a heart catheterization, which even then doesn't give you all the information you need, because you really want to see the disease in the walls of arteries, not just the internal lining or the lumen, we say. So Dr. Rumberg developed this idea that calcium could be used as an index. And then Dr. Arthur Agatston, which you may recognize that name because he popularized the South Beach diet a number of years back. He developed something called the Agatston score. And all that was a simple way to use the area of calcium and its density to develop a scoring system. And even though it was many years ago, that Agatston score is still the most common score used to report to you how much coronary atherosclerotic plaque you have. Normal is 0, anything above 0 is abnormal, up to many thousands. And the higher your score, the more likely you are heading towards heart attack, sudden cardiac death, or the development of symptoms that necessitate such things as stent implantation and bypass surgery. Now, I'm grateful that this conversation is gaining a lot of momentum because 30 years ago, it was very difficult because I had to educate doctors. All they wanted to know back then was how much blockage is there. And that's not how coronary disease works. That's a conversation for another day. But most heart attacks occur not because of progressive worsening of a blockage. It happens because of a mild plaque, maybe only blocking 30% of the diameter of an artery, ruptures like a little volcano. And that exposes the underlying tissues that are, we say, very thrombogenic, very blood clot forming. It provokes the formation of blood clots. So a 30 or 40% blockage can become 100% blockage within moments, and that's what a heart attack is. And that's why arteries are opened using stents, sometimes using what's called thrombolytic agents, which are agents that dissolve blood clots. But despite the growing conversations about CT heart scans and coronary calcium scoring, I still see lots of misinformation. We have plenty of great information from the likes of Dr. Matt Budoff, for instance, at UCLA. He's published huge numbers of studies, and others have too, validating the use of coronary calcium scores. But let's talk today about many of the things that you may not be told. So even if you had a CT heart scan and a coronary calcium score, what are you not being told? Well, one of the things not being told is that people say things like, well, if I have calcium, I don't care about that. I just want to know how much soft plaque I have. Well, that's a misconception. Calcium is an index of total plaque. That is all the components of atherosclerotic plaque. Calcium, yes, but also fibrous and fatty tissue. It's the fatty tissue, by the way, that's the most dangerous because that's the stuff that ruptures and causes heart attack. But calcium is an index or a gauge of total atherosclerotic plaque. So if somebody says to you, oh, we don't care about the calcium score because it signifies hard plaque, that's wrong. It's an index of total plaque. And that's been proven time and time again. Another common misconception is that you can't see any of the other elements beyond calcium. You actually can. You may not be able to precisely quantify them, but having looked at about 10,000 scans over the last 30 years, I can tell you, you can often, not always, but you can often see the other elements. You can see the contours of that artery. This can be important if you want to see progression or regression. The first time I saw regression of coronary calcium, many years ago, I was skeptical. That can't be true. So I went back and held up the before scan and the after scan. Yes, the calcium component of the plaque has shrunk dramatically, and the softer elements you could make out their outline had also shrunk. So you can't quantify it as precisely as calcium, but you can see it progress or regress, and it's really gratifying when you see coronary atherosclerosis regress. Another common misconception: how fast does the score increase? Well, let's think about this. If a score of 1 becomes a score of 2 a year later, that's a 100% increase, right? Even though it's an increase of only 1. What if a score of 1,000 increases to a score of 1,001 over a year? Well, that's an increase of only 1 unit and less than 1%. So it's a little bit misleading to say how fast scores increase. But let's, just for the sake of simplicity, let's just say if you have scores in the hundreds, say 200, 300, they typically progress at about 25% per year. Now, lower scores like 2 or 10 increase much faster. So it would not be uncommon if you did something silly like go on a statin cholesterol drug and your score is 10, a year later it's going to be 40 or 50, so much more than 25% per year. But once you get to the 100, 200, it tends to progress at about a rate of 25% per year. Another common misconception: that statin cholesterol drugs will slow the progression of your coronary calcium score. This is simply not true. We have a number of clinical studies now that tell us that statin drugs do not slow that 25% or so annual rate of progression. In fact, there's several studies that show it accelerates the increase in calcium. Now, because my colleagues are so in love with statin drugs, they often say things like, well, if it has more calcium in the artery, it stabilizes the artery. That's a fiction. It does not stabilize the artery. Calcium can occur in all different kinds of configurations in coronary arteries. Anybody who's done a lot of intracoronary ultrasound, where you pass an ultrasound probe into the coronary arteries and you see what the artery looks like in great detail, in cross-section. Anybody who's done a lot of that work, like I have, you can tell calcium occurs in all different shapes, sizes, and patterns. And to say that calcium that increases on a statin drug is stabilizing is nonsense. Another thing you need to know about is no calcium score can be used to justify invasive heart procedures. So if you had a score of, say, 400 or 1,000 or 2,000, lots and lots of coronary atherosclerotic plaque and calcium, some of my colleagues will say, well, you need to do the real test, a heart catheterization, and see if you need a preventive stent. Now, I'm talking about people who are not having symptoms. These are not people in the emergency room. These are not people who are passing out with chest pain. These are people like you and me going to work, riding our bikes, going for walks, having no symptoms. If you have a coronary calcium score that's high, it can never be used to justify procedures like heart catheterization or even a CT coronary angiogram. Why do they do that? Because it pays a lot of money. A lot of money. Even though when I first started doing CT heart scans 30-some years ago, I was accused of trying to make money off. Of course it wasn't. It was meant to be a preventive tool to track the progression or regression of coronary atherosclerotic plaque. But hospitals, after a few years, caught on. Hospitals and my colleagues caught on that you could use a coronary calcium score to scare people into getting procedures. And although that's wrong and it's malpractice, it's done every day in essentially every hospital because it's used, a high score is used to scare you, using words like, we can't be responsible for your safety if you don't have these tests. You're a walking time bomb. Or you need the real test to show how much disease you have. But you cannot use a coronary calcium score to justify procedures, even though it's done all the time. Another common misconception is that a CT heart scan and coronary calcium score cannot be used to understand the meaning of symptoms. chest pain, breathlessness, abdominal pain, whatever. Because heart disease doesn't always appear as obvious symptoms. It can show up as some uncommon symptoms. But you cannot use a coronary calcium score to explore what symptoms mean, because to understand what symptoms mean, you need tests like stress tests. That is, a graded exercise effort to see if your chest pain or other symptom can be provoked. You can imagine that a coronary calcium score is static. It is not provocative. It does not involve graded exercise. And so if someone says, well, we need to do a CT heart scan to understand the meaning of your chest pain or breathlessness or other, this is nonsense. You cannot use a coronary calcium score or a CT heart scan to try to associate symptoms with coronary disease. There are tests that do that, but it's not going to be a coronary calcium score. Another common oversight in CT heart scans is that you can see what's called pericardial and epicardial fat. This is fat in the pericardial sac. So the heart is encased in a very thick fibrous sac called the pericardium. There's a little bit of lubricating fluid in there so the heart can move freely. But fat can also accumulate. This is a form of so-called ectopic fat, fat accumulating where it doesn't belong, which tends to happen in people who have a lot of abdominal visceral fat, that is, fat surrounding abdominal organs. And so this is fat in the pericardial sac, some of which can cover the coronary arteries, so-called epicardial fat. And when you have pericardial and epicardial fat, it accelerates disease. Coronary atherosclerosis, your coronary calcium score, increases more rapidly. It can put you at risk for so-called cardiomyopathies, diseases of heart muscle, which are really bad things to have, and can increase your likelihood of atrial fibrillation. So you can see that fat, and so your CT heart scan might say something like, there's a moderate quantity of pericardial fat. You really can't distinguish pericardial from epicardial fat from a CT scan, so it's hard to really precisely quantify the epicardial fat that surrounds coronary arteries. So the thing that should be observed on your CT heart scan is the quantity of pericardial fat. Another thing often overlooked is the diameter of the thoracic aorta. The thoracic aorta is the big artery that's the first artery to emerge from the heart that receives the high pressure flow from your heart, from the contracting left ventricle. So the thoracic aorta is prone to enlargement. So it can be measured easily. The normal thoracic aorta measures about 3.0 centimeters. A little bit bigger in really big people, smaller in small people, but around 3.0 centimeters. What if it's 3.7 centimeters or 4.5 centimeters? Well, that means something is at work causing it to enlarge, which can be bad for two reasons. One, it tends to develop atherosclerotic plaque that can fragment. It's very common. It can fragment and send debris, usually to the brain. And that's when people say things like, I had a mini stroke. I lost the capacity for speech. It lasted for half a day and then it came back. That's typically from fragmentation of the thoracic aortic plaque. Also, you can measure the diameter, as I mentioned, and you want it to be about 3.0 centimeters. If it's enlarged, not only is it prone to develop atherosclerotic plaque that can cause strokes and mini strokes, it can also over time lead to a thoracic aortic aneurysm, which is a big problem. If it gets to about 5.5 centimeters, that's the standard diameter when you have your aorta replaced surgically. So you don't want to allow it to get to 5.5 centimeters. So if your thoracic aorta, say, measures 3.7 centimeters, you need to take action, such as the things we do in my programs, omega-3 fatty acids, magnesium to reduce blood pressure, all the things we can do to stop the progression. By the way, it's relatively easy to do, but you have to focus your attention on not allowing that thoracic aorta to enlarge. Now, if that's not mentioned in your CT heart scan, you need to call the scan center and say, I need to know my thoracic aortic diameter. If they say, oh, the doctor won't do that, insist. Make a nuisance of yourself. It's so important that you have the diameter of your thoracic aorta. Last oversight is that even though a CT heart scan, the settings are optimized for seeing the coronary arteries, you can actually see other things with great clarity. You can see, for instance, the lungs in great detail, far better than a standard chest x-ray. So, for instance, you can see evidence of prior pneumonias. You can see that if someone was a cigarette smoker even in many years past, you can see the evidence of that, especially of emphysema. You can see what are areas of absent lung tissue. We call them blebs. You can see early lung cancers. So the lungs should be looked at anytime you have a CT heart scan because of the incredible detail you can make out. Now, if none of this stuff was observed or reported on your CT heart scan, you want to call the scan center and really make a nuisance of yourself and say, hey, I need the diameter of my thoracic aorta. There was no comment. Take a look at your report. Maybe these things are in the report. But you might have to say, I don't see any detail on what was seen in my lungs. Of course, the progression, regression is something you have to do with serial. You have to have the scan repeated to gauge that. Now, if you want to put a stop to that otherwise inevitable 25% per year increase in score, you can do it. We've done it many, many, many times. Most important factors that you put to work to do that, omega-3 fatty acids. We now know from two very excellent studies, one of them by Dr. Matt Budoff at UCLA, who does incredible, great work on this topic, that higher doses of omega-3 fatty acids, typically above 3,300 milligrams, we use 3,600 milligrams of EPA and DHA per day, that facilitates regression, especially of the softer elements, the stuff that ruptures and causes heart attack. So it's become clear, while it's been debated for decades, how important are omega-3 fatty acids. We now know with two excellent studies that not only are they important in reducing plaque rupture and reducing cardiovascular events, it also facilitates regression even when statin drugs fail. Another very important, vitamin D. When we added vitamin D to my programs many years ago, it was the first time we saw calcium scores, coronary calcium scores, plummet. We saw scores of 700 drop to 400 or something like that. And that only happened when we added vitamin D. So we use a dose of vitamin D3, cholecalciferol, in oil-based gel cap only, never capsules or powders or tablets to assure absorption, to a dose to achieve a 25-hydroxy vitamin D blood level of 60 to 70 nanograms per milliliter or thereabouts. Another factor we pursue in my programs is the elimination of wheat, grains, and sugar. Not bacon, not pork fat, not butter. Why wheat, grains, and sugars? Well, because sugars, sucrose, fructose, other forms of sugar, and grains, wheat and grains that have the carbohydrate called amylopectin A, are the trigger for the liver to take those sugars and carbohydrates and convert them to triglycerides. That's a process called hepatic or liver de novo lipogenesis, making new fats. So the liver is very good at converting those sugars and carbohydrates to triglycerides. Triglycerides are packaged in the liver as very low density lipoproteins, VLDL particles. They gain access to the bloodstream. They themselves can cause coronary atherosclerosis, and those VLDL particles interact with LDL particles and convert them to small particles, which are very aggressive causes for heart disease. But it starts with consumption of wheat, grains, and sugars that get converted to triglycerides, VLDL, thereby small LDL. And then lastly, we have to address the status of your gastrointestinal microbiome. So we want to correct your colonic dysbiosis, or even more commonly, when you have coronary disease, small intestinal bacterial overgrowth. If you've been following my conversation, you know that small intestinal bacterial overgrowth, or SIBO, we say SIBO, is exceptionally common in Americans. And if you have coronary disease, it's virtually guaranteed that you have SIBO, meaning you've allowed fecal microbes to overproliferate in the colon, then ascend into the 24 feet of small intestine, where they live and die rapidly and release their toxic compounds, specifically endotoxin, that enters the bloodstream and is a major driver of coronary disease, coronary atherosclerotic plaque, and also of plaque rupture. So we address colonic dysbiosis and, more importantly, SIBO. We do it with my recipe for what I call SIBO yogurt. It's not yogurt. It looks and smells like yogurt, but it's not yogurt. We use my method of prolonged fermentation to allow multiple doublings of the microbe. That's how they reproduce, so that we get hundreds of billions of 3 species: Lactobacillus reuteri, Lactobacillus gasseri, and Bacillus subtilis. Hundreds of billions of microbes. We consume it half cup per day or thereabouts, and that has been spectacularly effective for us in gaining control, or being part of the program, in gaining control over coronary artery calcium progression. Now, if this interests you, if you need some guidance, I invite you to, of course, see all my other videos, my Defiant Health podcast, my thousands of blog posts, WilliamDavisMD.com. But if you really want support, conversation, two-way interactions, I invite you to join my innercircle.drdavisinfinitehealth.com.